In terms of other things, John, so when I'm looking at a neuroendocrine tumor, the first thing I do is I'm trying to think about classification, and I'm trying to think about all the different factors that I'm looking at. So what are some of the factors maybe that you look at in your clinic when you're trying to understand and classify these tumors?
Right. So we've already talked about several of them, but there are lots of ways of categorizing neuroendocrine tumors. And when you're seeing a patient, you want to be able to put that particular patient into the appropriate framework. So we talked about grade and differentiation. We talked a little bit about primary site, which is obviously very important. Each of these tumors have unique clinical features, whether, even tumors that are quite close to each other, like ileum versus appendix. They're both technically midgut, but very different as far as clinical behavior. Functional or non-functional, in other words, is the tumor hormone producing or not? Sometimes that thing can be a little bit ambiguous and it can change over time. Tumor burden, is tumor burden high or low among patients with stage 4 disease? Is it liver dominant or not? That's very important because a lot of our treatments are liver directed. And are the tumors expressing somatostatin receptors uniformly? Because that's important in terms of considering both somatostatin analogs as well as radiolabeled somatostatin analogs. So all these various prognostic and predictive factors are important to establish at baseline, and they can help direct treatment. What are your thoughts on sort of diversity of nets and how it impacts treatment? Do you have any other thoughts on that?
No, I think you did. I think we probably practice in a very similar fashion. I think it's important to recognize that the group of neuroendocrine tumors is incredibly heterogeneous. Yeah. And, I would say probably more so than any other malignancy that we normally treat. And it's really, we have these slow growing tumors that potentially where lifespans can be many decades to these very aggressive carcinomas where we really have to act quick. Exactly. So I think it's really important to spend time and to get all your tests done and to really properly classify and understand what kind of a neuroendocrine tumor the patient has so you can offer that patient the best treatment and be able to give them the best possible outcomes. And I think it's really important to invest that time at the beginning to really understand the tumor.
Exactly.
John, as we're talking about what we do, all these factors, are there any of those factors that you saw that would maybe lead you to understanding that perhaps this patient doesn't need treatment to start and we can take a watch and wait approach? What factors would lead you to that, if any?
Right. So the first factor when you take a watch and wait approach is that you're referring to a patient, in almost all cases, with an incidental diagnosis, a patient who's not having symptoms. If the patient's having tumor-related symptoms, that patient needs to be treated. There are really two circumstances where you might think of a watch and wait approach. The first is a small localized tumor, and usually in that case we're talking about a pancreatic net smaller than 2 centimeters. There's accumulating data that low-grade pancreatic nets incidentally discovered lower than 2 centimeters can be safely followed. But you probably want to choose that strategy in a patient who's older, who has comorbidities. A young, healthy patient, the concept of lifetime surveillance is probably a little bit risky and not that attractive.
I think it's important that the patient can also be followed up as well, that right. You know that they're going to come back and that you're not going to lose track of them.
Right.
Yeah.
So in that circumstance, you're basically debating watch and wait versus a potentially curative surgery, but one that has a lot of morbidity. Then there's the incurable stage 4 circumstance where a patient might have incidentally diagnosed as a result of undergoing a scan for a different reason. Here you're trying to decide whether to basically start a somatostatin analog or watch and wait. And the appropriate patient for a watch and wait approach is really one that, again, is asymptomatic, no hormone-related symptoms, no carcinoid syndrome, and probably a relatively low tumor burden. And in that kind of patient, you can discuss whether to start treatment, typically with a somatostatin analog, which is low risk, but still involves some side effects, cost, and discomfort to the patient, or take a watch and wait approach. And even though somatostatin analogs substantially prolong progression-free survival, we know that from the PROMET and CLARINET studies, there's no evidence as of yet that starting treatment early impacts overall survival, because if we look at both those studies, all patients pretty much crossed over from placebo, but there was no impact on survival. So we don't know that there's no evidence that the watch and wait approach is harmful to patients.
One thing we should mention though is a ProMed study at the 6-month mark of the placebo patients, 50% had progressed. So I think it's important that we do keep, if we are electing to, it's a discussion with our patients to have a watch and wait approach, and it's important that we do follow them up, realizing that at least half of them, if not more, are going to progress at some point, and we want to be able to initiate treatment at the right time.
Exactly.